Hello and welcome to our next module in the American Indian webinar series through the Maternal Health Learning and Innovation Center. In this module, we'll be talking about evidence-based and evidence-informed maternal and child health strategies when working with American Indians and Alaska Natives. Again, my name is Dr. Donald Warne, and I am Oglala Lakota, originally from Kyle, South Dakota on the Pine Ridge Indian Reservation. And I currently serve as a family physician. I'm also co-director of the Center for Indigenous Health at Johns Hopkins University. For this module, we will look at some definitions as well as overview of historical trauma, the boarding school era, and adverse childhood experiences and toxic stress, and how that creates some unique needs when we're looking at developing evidence-based and evidence-informed practices to address maternal, infant, and child health disparities. So we will look at a few evidence-based practices and evidence-informed practices. I'm sure many people are familiar with their programs through HRSA, the Health Resources and Services Administration. We'll also look at some of the programs and challenges within the Indian Health Service. And then finally, one of our very exciting evidence-based practices in this space is the Family Spirit Program. And that's housed and offered through the Johns Hopkins University Center for Indigenous Health. And then we'll just conclude with some next steps and considerations for developing effective programming in tribal nations. And I think it's important to acknowledge the long-standing history of trauma that Indigenous peoples have had to endure, and recognizing that loss of land, loss of territory, loss of language and culture has had a devastating impact on the health and well-being of Indigenous peoples. And that really is the opening framework to consider when we are developing programs to address maternal, infant, and child health in tribal populations. So we need to recognize that there is historical trauma and, unfortunately, a history of genocide against American Indian and Alaska Native people that has led to some of our chronic disease disparities, as well as disparities in maternal and child health. There's also a history of boarding schools in the US and residential schools in Canada, in which the children of Indigenous families were forced to many times leave their home communities and get placed into boarding schools. So they were compelled to participate in boarding schools, and it was not optional. And the way that the US government did this is that when the tribes were put onto reservations, they became dependent on the federal government for food programs, because when we were on reservations, we lost food sovereignty and control of food systems, so then became dependent on federal government programs. And what the families were told was either give up your children to go into boarding school, or we will withhold your rations. So essentially the choice was to either give up your children or starve. So really difficult piece of history in the United States that has had a huge impact on intergenerational health and outcomes, particularly for maternal, infant, and early child health disparities. So historical trauma has been defined as the collective emotional wounding across generations that results from massive cataclysmic events or historically traumatic events. And this picture is from the Carlisle Indian School, which was a boarding school. And we saw, unfortunately, just hundreds and hundreds of American Indian children placed in this boarding school. And this boarding school, like many others, has a large graveyard right next to it, because we tended to see high rates of death of children while they were at boarding school. So when I think about this, it's not just an impact, obviously, on those children who died while they were at boarding school, but what is the impact on the survivors? And recognizing that we have entire generations of Indigenous peoples who had to endure these types of experiences. And as a child growing up and witnessing so many of your friends and classmates die at an unnaturally high rate has a long-term impact on the well-being of those individuals. Just very briefly, trying to understand what is the potential scientific basis for historical trauma, I think that epigenetics will provide a scientific platform to better understand intergenerational trauma. So epigenetics refers to the study of changes in the regulation of gene activity and gene expression. And this is not just about the sequence of DNA nucleotides, it's actually changes to the DNA. And there's some preliminary evidence that shows that these changes can be passed one generation to the next. So it's possible that epigenetics will provide a scientific platform to better understand intergenerational trauma. Other considerations, we have a lot of stressors during pregnancy. Obviously, that has a huge impact on maternal and infant health outcomes. And we haven't adequately studied this in tribal populations. And we know that we have a lot of unplanned pregnancies. In many cases, we have young people who are self-medicating their own trauma and wind up getting pregnant in an unplanned manner. And quite often, we still see self-medication and addiction and substance use even during pregnancy. So a huge challenge related to long-term and intergenerational impacts of trauma and self-medication. Also, we have seen some significant improvements in nutrition in recent years, but historically, the WIC program, Women, Infants, and Children, which is operated through the United States Department of Agriculture, historically that was basically a baby formula distribution program in many of the tribal communities where I worked. They're doing a much better job now of promoting breastfeeding. And we do know that breastfeeding is healthier than formula feeding. And if we have a population of children who are breastfed, we tend to see healthier adulthood in that population as compared to formula feeding. But I think inadvertently, we wound up seeing higher rates of formula feeding because of the programs offering free formula to new mothers. The FDPIR is the Food Distribution Program on Indian reservations. That's another USDA or United States Department of Agriculture program. And this offered free food to people who were impoverished and living on the reservation. So food distribution program on Indian reservations. And now when we think of traditional food, a lot of people think of fry bread as a traditional American Indian food. And actually it's not a traditional food for us. It's actually people doing the best they can with the commodity foods that were available through the food distribution program on Indian reservations. So historically, we never fried dough. That's actually an outcome of the USDA commodity food program. And as a result, we wind up seeing unhealthy outcomes in terms of higher rates of obesity, diabetes, heart disease, and cancer that is mediated in many ways through poor nutrition. They have improved the commodity food program significantly over recent years, but historically, and what I was exposed to as a child was very unhealthy foods that were prepackaged. So prepackaged meats, prepackaged and processed cheese. There was a grape juice that I think was basically sugar water with purple food coloring, powdered eggs, powdered milk. And on the right, this is actually a container of pure corn syrup, which is basically an engineered sweetener that's not natural food. And if you look, I know it's in fine print, but it says use in baby formula. So we were encouraging at one point the use of these unnatural foods for infants in American Indian and other impoverished communities. And not surprisingly, we see worse health outcomes as a result. So it's important to be cognizant of the fact that some communities are still dependent on WIC programs and food distribution programs that may or may not have healthy foods. So as we're working with our communities and trying to develop evidence-based programs, we need to be cognizant of the food supplies that are available locally. And we could have all of the nutritional knowledge in the world and make wonderful recommendations, but if we don't have access to healthy food, we are at significant disadvantage from a population health perspective. Unfortunately, we've also seen higher rates of adverse childhood experiences in many of our tribal populations. I've been involved in studies looking at these disparities, and we tend to see higher rates of adverse childhood experiences in impoverished communities, and that's true for American Indians as well. And we know that adverse childhood experiences correlate with poor health outcomes. This particular pyramid is from the CDC, Centers for Disease Control and Prevention, specifically the National Center on Injury Prevention. And what I like about this particular pyramid is that the adverse childhood experiences themselves are not at the base. Even CDC recognizes that there's generational embodiment and historical trauma that puts some communities at greater risk for adverse childhood experiences based on those social conditions that are the outcomes of historical trauma. And then with adverse childhood experiences, we can see disruptions in neurodevelopment, social and emotional development, challenges in school, health risk behaviors, and then early onset of disease and death. So as we're developing maternal and child health programs, we also need to be cognizant that some communities are at greater risk for adverse childhood experiences. So as we're developing programs and evaluating them for their evidence base, we need to be cognizant of some of these risk factors. And as we know, adverse childhood experiences correlate very strongly with poor health outcomes throughout the lifespan. So higher rates of chronic disease, higher rates of mental health considerations, and higher rates of social determinants of health. So if we have more ACEs, we tend to see more poverty, less educational attainment, and ultimately poor life potential outcomes and health outcomes. And the adversity does not end at age 18, correct? We also see adverse adulthood experiences and toxic stress. When people are living within impoverished communities that might be marginalized or discriminated against, we tend to see toxic stress, which also has a negative impact. And this is also true for the childbearing years. And it's important to keep in mind that children who've gone through adversity and abuse and neglect eventually become parents, right? And what have they learned about parenting? So this really needs to be considered the framework or the backdrop upon which we're developing and testing interventions to promote child, maternal, and family health. So in terms of evidence-based practices and evidence-informed practices for improving maternal and infant health, we know there are several programs out there already. So there's Healthy Start through HRSA, the Health Resources and Services Administration. There are the MCV programs, Maternal, Infant, and Early Childhood Home Visiting Programs. There's the Title V State MCH Block Grant and its related programs. There's also Indian Health Service, but as we will see, the underfunding of IHS has had a negative impact on our maternal and child health programming through the IHS. And then finally, we'll talk about Family Spirit as well as an evidence-based practice that should be scaled up and expanded. So Healthy Start is again through HRSA, through the Maternal and Child Health Bureau, and they offer education, they promote positive birth outcomes, and protect the health and well-being of mothers and children. And to do this, they promote their provision of adequate prenatal care. Some populations are still, unfortunately, receiving late and inadequate prenatal care. Healthy Start also promotes positive prenatal health behaviors and recognizing that the health of the mother prenatally has a very direct impact on maternal, infant, and early child outcomes. We also need to meet basic needs, including nutrition, housing, and psychosocial support, and recognizing that the nutrition of the mother will have a direct impact on the health of the baby. So we have to support nutrition as well, and try to reduce barriers to access to healthcare services and try to enable empowerment of the clients. So Healthy Start is administered by local agencies in each state, and the services vary from state to state. But generally speaking, there's care coordination and involved in care coordination. We also see things like case management. There's promotion of breastfeeding and childbirth education. I think it's important to recognize that some women have challenges with breastfeeding. So there's been some preliminary look at how we might promote breastfeeding through banking of breast milk and other programs. Historically, for Indigenous populations, we had wet nurses or cross breastfeeding, where we'd have women in the community who could breastfeed for those in the community who are struggling with breastfeeding. So we have to be cognizant that breastfeeding is best for the baby, but we also have to be sensitive to the fact that some women struggle with it. We need to support them. So Healthy Start does provide parenting education and support, smoking cessation assistance, because smoking during pregnancy and smoking with an infant in the home is dangerous for that baby, higher rates of SIDS and other comorbid conditions. Nutritional services and counseling, psychosocial counseling, home visit support groups, and other programs based on needs. So these are wonderful programs through Healthy Start. I think one of the biggest challenges that we face is that the Healthy Start grants are very competitive. And of about 100 programs nationally, there's only 2 Healthy Start programs that are in tribal communities. So one of our challenges is to look at how Healthy Start programs are funded. And what we tend to see is that communities that have the resources and assets to hire a grant writer, for example, are more successful at getting these resources than the more impoverished communities. And ironically, the outcome is that the communities who need these programs the most are the programs who are not writing competitive grants. So I think we really need to look at how Healthy Start is funded and how the programs are developed and which communities are selected. That the health and well-being of a child and an infant should not be based on the grant writing skills of the community stakeholders. But essentially, that's what it's evolved into. It's a wonderful program, but not every community that needs these services are getting access to them. For MHLIC, maternal, infant, and early child home visiting programs, they support pregnant people and parents with young children who live in communities that face greater risks to achieving good maternal and child health. So the program aims to improve maternal and child health, prevent child abuse and neglect. So we're trying to reduce adverse childhood experiences, also reducing crime and domestic violence, trying to increase family education and earning potential, promote the children's social development and ability to participate in school, and then connect families to those needed community resources and supports. So the home visiting programs have been wonderful. What we need to see is long-term sustainability of these efforts, and not just support through grants, but also how might we change policies to make sure that these are reimbursable types of services, because the home visitors are doing some wonderful work. They can support healthy pregnancies, provide information and education on things like breastfeeding and safe sleep practices, and reducing childhood injuries and promoting good nutrition. Can also encourage early language development and learning at home, teach positive parenting skills. And again, if we have a population of people who went through boarding schools, for example, what have they learned about parenting? So we can look at this from a parenting skills development, but also could make it culturally relevant as well. MHLIC works with caregivers to set goals for the future and find employment, and also connecting families again to those other services that are needed. In terms of challenges in tribal communities, there is a 3% set aside for tribes for MHLIC, but again, those are competitive grants. So for the tribes, they're having to compete with each other for these very important evidence-based and evidence-informed programs like Healthy Start and MHLIC. So we need to look at this from a broader policy perspective on one hand, and recognize that the current funding systems are excluding some of the populations who need these services the most. But perhaps with your programs, what might we do to improve tribal engagement with the existing Healthy Start and MHLIC programs? Other programs, of course, the Title V state MCH block grant that's administered through HRSA, and the authorizing legislation is Title V of the Social Security Act. And written into the law, states receive funds directly to address maternal and child health, but the tribes do not get funding directly from Title V. So whether or not resources get to the tribes actually depends on the states. Some states work very effectively with tribal nations, others do not. So it's important to keep this in mind, that as we're distributing block grant funding to address maternal and child health, we don't have equitable distribution of those resources to tribal nations. It really is dependent on whether or not the state has a good relationship with those tribes. In terms of Indian Health Service, their funding and programming, IHS is severely underfunded. We don't have nearly the amount of resources needed to meet the health needs of our people. So the MCH outcomes are just not good. We have late prenatal care. That's the norm in Indian Health Service. It's actually unusual to have first trimester prenatal care in the IHS population because of limited resources and limited engagement with the health system and with the communities. So a recent publication in the Journal of Rural Health from March of 2022 showed that American Indian and Alaska Native women had increased risk of late prenatal care initiation and are more dissatisfied with the timing of prenatal care initiation. This is in the state of North Dakota, but it's common across other states as well. So we have plenty of evidence that shows that the underfunding of IHS is leading very directly to disparities in access to maternal and child health care for American Indians and Alaska Natives. The last program I wanted to talk about is the Family Spirit Program, which is through the Johns Hopkins Center for Indigenous Health. And it's an evidence-based program with lots of publications now, and it's culturally tailored home visiting program. So it's kind of like a McVie designed for American Indians to promote optimal health and well-being for parents and children. Very good website if you're interested in looking at Family Spirit in more detail. But very briefly, it addresses intergenerational behavioral health problems. And again, we have to have that intergenerational trauma and challenges as a framework to understand our health disparities. But more importantly, they're applying local cultural assets and recognizing the benefits of cultural connectedness and cultural programming and appropriate language. And then they overcome deficits in the professional healthcare workforce as well. It's the only evidence-based home visiting program ever designed for, by, and with American Indian families. And as of now in 2022, it's used in over 100 tribal communities across 16 states. So this is the type of program that needs to be scaled up. The Family Spirit model goes above and beyond McVie programs in several areas. It leverages cultural assets and indigenous populations and uses indigenous understanding of health and cultural approaches to health. They encourage the use of paraprofessionals to deliver the program and really expanding on community health workers and home visitors, but again, using culturally relevant methodologies. And then they also address behavioral health disparities in a very formal capacity and using those local assets and strengths of cultural connectivity. There's been 3 randomized controlled trials, including the most recent called Cradling Our Future. It was funded through the NIH. And it enrolled 322 American Indian mother-child dyads. And they showed that Family Spirit significantly improves parenting efficacy, reduces mothers' drug use and depressive symptoms, and improves social, emotional, and behavioral development for children through 3 years postpartum. So this is a wonderful program. And what we need to do is with these evidence-based programs is invest more resources so we can have these types of services available across all Indigenous populations who are dealing with these terrible disparities. All right, that brings us to the end of this particular module. I hope that was helpful in terms of understanding some of the evidence-based practices and evidence-informed practices to address American Indian and Alaska Native maternal, infant, and child health. Thank you very much.